nursing educator coordinator. We welcome you to another Sovah Health CME program. As you can see on the slide tonight, we'll be talking about helping patients find all the care they need. The program this evening provides 1.5 hours of physician category 1 AMA CME credit and 1.5 hours of Virginia Nurses Association CE credit. Sovah Health is accredited by the Southern States CME Collaborative, of which the Medical Society of Virginia is a member. In addition, Sovah Health is accredited to the Virginia Nurses Association to provide nursing CE credit. This program this evening was developed to promote certain physician and healthcare provider attributes, including our providing patient-centered care, employing evidence-based practice, and our working in interdisciplinary professional teams. This program was initially developed from an educational need or gap identified concerning improving our knowledge on ways to better plan for patient dispositions when inpatients are in our emergency room or clinics. As we developed the program and realized the importance of determining capacity for patients to make their own healthcare decision, we realized how important this information can also be for those healthcare professionals that are dealing with informed consent, giving permission for procedures, as well as for developing disposition plans. I'm right to remind anyone who's not muted their phone to please do so. We're getting a little feedback right now. Ms. Lipscomb, Ms. Huffman, Dr. Lewis, myself, and members of the Sovah Healthcare Committee have no commercial relationships to disclose to you for this evening's program. Likewise, there is no commercial support for this program. It is supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who founded the Southside Urology Nephrology Clinic, also known as the Danville Urologic Clinic, or DUC, upon his retirement, provided a generous donation to create or endow the support of honorariums for CME programming for all healthcare professionals here in Southside Virginia, and in our community. You will this evening receive, through one of two mechanisms, a program evaluation that'll have some 7 questions. We ask you to take a few minutes to complete this when it's emailed to you. We ask you, as you fill it out, there's a question, I think number 4, asking what will you take away from this program this evening that you'll change in your practice. Please, that's for everyone, not just the immediate direct healthcare providers. We all practice our profession in our own scope of practice. So take a few minutes. We review these. These are very important in our program assessment and program development. At the end of the evaluation, one of the last questions it will ask you is to put in your name and your email again. And we do that because that is the name that will be on your CME or CE certificate. So please give us your full name, no nicknames. If someone is participating in the program with you tonight, and we do not have them as a pre-registered participant, we are more than happy to give them credit for the attendance. If that's the case, please let one of us know, Mary Kent, myself, or Jennifer Goodman, so we can be sure that everyone gets credit for the program. In the chat box towards the end of the program, you will see a QR code that will allow you to photograph that or click on that, link to that, and that will take you to the evaluation form. You'll also get one by email. You only have to do one if that helps you in your doing the evaluations for us. We like to remind the residents that you do not have to keep up with CME certificates. Your program coordinator, Dara Johnson, or Lori Galvez will track your participation. Evaluation forms are not required except for nurses and nurse practitioners, and the Virginia Nursing Association does require that for nurses and nurse practitioners to receive credit that they do complete an evaluation form. If you have any question about the program or the forms, etc., please feel free to reach out to myself, Mary Kent, or Jennifer Goodman. I like to each night we do these programs thank them for their help. They actually do all the heavy lifting to make the program possible through the many documents and other things we have to do. I know that both our speakers and Ms. Lipscomb will just be delighted for you to have comments or questions. You can raise your hand in the chat or email that question. Mary Kent will be monitoring that for you, and we'll get it answered when you speak to ask a question. Once you finish, please mute your phone so we don't get feedback. You're welcome, encouraged to make as many questions or comments. In fact, the more we have, the more vibrant and effective programs can be. I want to highlight one upcoming program. As some of you know who have participated in our programs, we have traditionally not done programs in July and August due to so many people being away on vacations and other things getting in the way in the summer. But we've had so many things that we've been asked to do. We will have one program in August. On Thursday, August 21st, that's about 3 weeks from now, we're delighted to have Dr. Alexander Reddy, who is the director of Duke Motility Lab. This is located in the Raleigh area rather than on Duke campus. He's going to be talking about esophageal disorders. If you're not aware, there have been numerous recent developments in specific therapies for quite a few esophageal disorders, so that as you see patients, and this is such a common symptom patients complain with, something related to swallowing or eating, that this is a really, really good update for that purpose. That being said, I am just delighted and so grateful that Ms. Carla Lipscomb, the Director of Case Management at Sovah Health Danville, is going to moderate our program. Ms. Lipscomb began her healthcare professional journey receiving her BSN at the Winston-Salem State University. She began her work as a neurointensive care, or NICU if you're in the business, nurse, and then progressed to nursing leadership and post-anesthesia care, or PACU units. She subsequently, while being a leader in multiple clinical sites, she became a certified case manager, and she filled a role in leadership and case management at several, if you will, regional healthcare centers, including previously being the clinical nurse manager in the Duke Private Diagnostic Clinic, the PDC, if you're someone who's aware of Duke. She has a huge, huge role in our patient care at Sovah Health, managing and helping us with patients flow through the hospital and their inpatient experience, and then facilitating their dispositions as they go home. So Ms. Lipscomb, thank you so much. I will let you take over the program, and Ms. Huffman, if you want to bring your slides up, it should knock mine off. And I thank you both so very much. She'll introduce Ms. Huffman to everybody. Thank you.
Good evening, everyone. Again, my name is Carla Lipscomb, and I will be introducing Miss Mary Molly August Huffman. Miss Huffman, she actually started her career at the University of Virginia, majoring in English and a minor in history. She continued her education at the University of Richmond School of Law with her doctoral degree in law, after which she started practicing as a litigation associate, representing large corporations doing business in West Virginia in the defense of civil litigation cases. She has been practicing law for over 33 years, representing hospitals, health systems, physician groups, behavioral health providers across the country in a variety of specialized areas. She routinely provides advice regarding hospital safety, security, EMTALA, HIPAA, and reporting requirements, electronic health records, risk management, internal investigation, guardianship, judicial authorizations for treatment, scope of practice requirements, and regulatory compliance. She does provide training and speak to hospitals, associations related to Patient Safety and Quality Improvement Act. She currently practices in her own solo practice. She's a solo practitioner representing healthcare providers and healthcare entities at the Huffman Health Law in Richmond, Virginia. She is no stranger to us. Periodically, I reach out to Ms. Huffman, and she and I have conversations on difficult legal situations that may be occurring at Sovah. In addition, she is a professional member of 9 different organizations. She's had over 30 speaking engagement and writing topics, including the Patient Safety and Quality Improvement Act and the formation of PSOs. She has several court admissions, including the Supreme Court of Virginia and several other states. She is a member of several community awards and recognitions, including the Virginia Business Magazine, Legal Elite, Virginia Super Lawyers Rising Star, and the Richmond Magazine. So I do want to introduce to you all Ms. Huffman. Ms. Huffman, you may begin.
Thank you, Carla. I so appreciate that. And always love working with you all. So thank you for the opportunity to be here this evening. From the technical side, can you see my screen or my slides?
Yes, I can see your slide.
Okay, fantastic. So the team has asked me to be here this evening to talk about when and how to determine mental capacity to make healthcare decisions. And so we're going to talk a little bit about what capacity versus competency looks like, and really as a medical team, particularly for the physicians, what that looks like and what's required in Virginia. I'm required to say that this is for discussion purposes. It's not true legal advice. So certainly feel free to follow up with your legal team if ever there are specific questions. All right, so jumping right in, patient rights. Any person who is capable of making decisions regarding his or her medical treatment has the right to do so. It seems quite obvious, right? But the Virginia General Assembly, this was really important to them when some of the laws we're going to talk about tonight were passed. What they wanted to make sure our laws reflect are that folks, patients, people can make their own decisions until we determine they lack capacity. And there's a very specific way to do that in Virginia and very specific documentation that we have to have. But up until the moment that that happens, that patient is in his or her own shoes, if you will. And anybody else's thoughts, whether it's family members or others, really just kind of sit on the shelf, because we really can't take their consent if the patient has the ability to make his or her own decisions. And I think the second bullet point is so important. Poor judgment does not equate to lack of mental capacity. And I'm sure you all, like me, have seen so many what seemed like really poor, outlandish, whatever the word you may want to use is, decisions by patients, thinking that certainly it's not a decision you or your family would ever make. But if it is just a quote crazy decision or a poor judgment decision, that in and of itself does not allow us to move the decision making to somebody else. That person gets to make their own decisions, even if it's something that doesn't seem appropriate or right. An individual's right to make their own healthcare decisions is rooted in a whole bunch of different places. So certainly Virginia law, but also common law, just the right to make one's own decisions. And then on the federal level, the Medicare conditions of participation under CMS, which the hospital operates under, also requires that we allow patients to make their own decisions. And lastly, Joint Commission standards. So capacity versus competency. What is that and what does that look like? Those two words are often interchanged. You may well have heard it yourself, that folks will say, oh, they're not competent, or, oh, they lack capacity. While the two words often are used interchangeably, they are not the same thing. And we really should not use one for the other. They are completely different legal terms, and they apply in completely different ways. It always worries me when I get a medical record that uses the word competency, that somebody thinks the patient is not competent, because really none of us in the hospital space can determine competency. So let me start at the beginning. Competency is a legal determination by a judge or a court. So a judge has to say that a patient is incompetent, and that has to happen in a court hearing or other court document. A physician or a medical team cannot determine competency. And really what it means is one's overall ability to participate in legal matters. So in a criminal setting, it might be, is that individual competent to stand trial? When a judge is deciding a guardianship or a conservator proceeding, he will rule on competency. But again, if you really just in your mind think of competency as being only with a court and only with a judge and not with any of the medical team that works in the hospital. And then we're going to flip over to the left side of this screen for capacity. That is completely a medical determination. And in Virginia, it has to be made by a licensed physician. We'll talk about some other providers that can weigh in on that, like a psychologist. But it is completely a medical determination by a provider in Virginia who is licensed by the Board of Medicine or another licensing board under the Department of Health Professions. So while we, and I'm not a doctor, but when I say we, those of you listening, can make capacity determinations, but not competency. On the flip side, the judge can't decide capacity. Most judges know that. There have been times where I've had to make that argument or educate the court on that. But most judges do understand that difference, that they are there for competency, not capacity, and you all are there for capacity. It involves assessing an individual's ability to make an informed decision for him or herself. So if we put on the hat of, does that patient have the ability to weigh the risks and the benefits of the proposed medical treatment you all are recommending? Do they have, it's a functional assessment of that individual's ability to understand the information related to the decision and also to appreciate the consequences of that decision. Again, your physician license in Virginia, in the Commonwealth of Virginia, means that as a physician, you have the ability and knowledge to assess a patient for capacity. And I think that's important too, because over the years that I've done this, not often, but sometimes I'll have a physician say, well, I'm not comfortable assessing a patient for capacity. That's not something I routinely do. And the reality is that, again, by the sheer nature of your license under the Board of Medicine, you in Virginia are viewed as having the ability to assess a patient for that. We will get into where psychiatrists and psychology perhaps can come in and help us as one of those decision makers, but any physician should feel comfortable to do that. And it goes kind of hand in hand with the informed consent process. So if you are getting ready to consent a patient for any procedure, and you feel that that patient can't understand the risks and benefits or alternative treatment options, which may include no treatment, then that is really where the documentation has to happen. That at that point, we start the process of, quote, taking that patient out of his own shoes for making his own decisions. And that treating provider is the first stopgap for that. We will get to the second stopgap because there are two evaluations that have to happen. But I think the real point I want to make here is the difference in those two definitions, as well as the fact that any physician should feel comfortable doing that. Again, it's not peeling that onion back super far. If details of a psych analysis are needed or a psychiatric disorder, or perhaps it's an Alzheimer's or dementia concern, then it's always appropriate to bring in a specialist. But I just really want to reiterate that any physician can evaluate their own patient for capacity and document it. I know this sounds like a lawyer-ease comment, but of course, if not documented, it's always viewed as not having been done, unfortunately. So if you assess a patient for that and you do feel that that patient can't weigh the risks and benefits, then just ensuring that it gets documented contemporaneously in the medical record. So Virginia's definition of incapacity, every state kind of has their own laws, their own analysis of what this looks like. But here in Virginia, this is our definition for the for an adult capacity evaluation, different for a minor, but it is the inability of an adult patient because of mental illness, could be intellectual disability, or any other mental or physical disorder that precludes communication or impairs judgment. And then the second prong, it has to be all the prongs, that disability or mental illness or what have you precludes them from making an informed decision about providing, continuing, withholding, or withdrawing a specific healthcare treatment or course of treatment, because he is unable to understand the nature, extent, or probable consequences of the proposed healthcare decision, or to make a rational evaluation of the risks and benefits, or alternatives to that decision. For purposes of this article, persons who are deaf, dysphagic, or have other communication disorders who are otherwise mentally competent and capable to communicate by means other than speech shall not be considered incapable of making an informed decision. And that fourth and last prong is important too. It's saying that just because we may not be able to communicate with that patient, maybe they are deaf or maybe they're blind and use sign language, that in and of itself does not allow a treatment team to take consent from the family member or other authorized representative. So, whether it's a whiteboard that they can scribble on, or a hearing device, or whatever the apparatus may need to be, we're supposed to find a way to do that rather than taking them out of their own decision making because of something like that may preclude their ability to communicate with us on the same basis we might with other patients. This next slide I put in there for you all. I have shared with Dr. Moore and his team that you all are welcome to have and use these slides. And this is just sample language for a capacity evaluation. It does not have to say this exact verbiage at all. Oftentimes when I'm creating an affidavit or a physician's evaluation for things like a guardianship, I will use this language in it. And so I pulled it out. It is intended here for the treater. Again, doesn't have to be verbatim and is maybe too formal for many of you, to put it exactly in the medical record. But essentially saying, here's my name, I'm a doctor, this is my patient, currently under my care, and it is my medical opinion that because of, and those are the three buckets that it would have to be one of. So is it because of mental illness? Is it because of an intellectual disability? Or is it because of some other disorder, which would be the third one? Which is the reason that you think the patient doesn't have capacity and that they're unable to weigh the risks and benefits? And you'll see I put specify what the treatment is under bullet point 2, so that we're really customizing this, that it's not just copy and paste, but why this particular patient can't understand that the risks and benefits, and that they're not likely to become capable of making that decision in the short term. What the courts want to know there is this somebody that maybe if they had a medication or two, or if we gave them 48 hours, they would improve? But we are essentially saying they can't weigh the risks and benefits and are not likely to be able to do so in the short term, such that we do need to find an alternative decision maker to help make these decisions for them. This next slide, I have just, there are lots of definitions in this particular chapter of the Virginia Code that relate to this, but these two to me are the most important, and I'll tell you why. Capacity reviewer, that definition has changed. Most of this law has been with us for as long as I can remember. But the capacity reviewer definition did change recently. It is a licensed physician or clinical psychologist who is qualified by training or experience to assess whether a person is capable or incapable of making an informed decision. So when I talked about taking a patient out of his or her own shoes for making his or her own decisions, we talked about the treating physician making the first assessment. Virginia said, we don't want to just take that decision-making ability away easily. We want there to be a second evaluator. And this part a lot of times gets missed, quite candidly. It needs to be an evaluator who is not involved in that patient's care. And it needs to be either a physician or a clinical psychologist. And those two categories of people get the title capacity reviewer. So for example, if you have a doctor who has a physician-patient relationship and feels that their patient can't consent to whatever treatment is needed. He or she would note that and then ask for a consult of somebody not involved in the care of that patient. Kind of a clean read, if you will, just for purposes of asking that patient questions about their capacity and whether they understand what's being proposed. And again, it needs to be a physician. I always like for this capacity reviewer piece to be somebody from the psych department, whether it's a psychiatrist or a psychologist, if that is possible. Does not have to be, could be a hospitalist, could be somebody else that is available. But if we are able to bring somebody from the psych field in for many of the clinical situations, I think that is helpful. And then the second definition I have here of healthcare is just so broad. I won't read it to you verbatim because it is long, but just letting you know that the category of where we have to really think about capacity is so broad. It's really everywhere that care is being provided within the Commonwealth. So when you are assessing a patient and deciding whether that patient is capable of making their own decisions, it can apply to a particular healthcare decision. So it could be one discrete healthcare decision. It could be a specified set of decisions or all healthcare. And that's another area where I've had questions over the years, because sometimes people think, well, either you have capacity for everything or nothing. And it's really not that way. It can be spliced out to maybe they just don't have capacity for this one particular decision for a whole host of reasons. Or maybe it is everything. And so making sure that that part of it is included too, I think is important. The last bullet says, no person shall be deemed incapable of making an informed decision based solely on a particular clinical diagnosis. So that means diagnosis X, it could be cancer, it could be what have you, or Alzheimer's. That diagnosis in and of itself, just saying, oh, that person has Alzheimer's, does not mean that they lack capacity to make decisions. So the diagnosis certainly is important, but it does not equate under Virginia law to lacking capacity. This whole evaluation piece by the two physicians or a physician and a psychologist still has to happen and be documented. So we've talked a bit about this. I'll fly through this one. It's, again, the treating physician and a second physician, that independent evaluator, if you will, who's going to assess the patient for capacity. Now, the only time there's an exception to this is if the patient is unconscious or has some profound impairment, like from stroke or what have you. Then that second reviewer, that independent reviewer who's not caring for the patient, is not needed in those situations. Kind of for obvious reasons, I think. So that would be the only time that the treating physician would be the only evaluator. Now, regardless of how we get to the spot of the patient lacking capacity, whether it's the one physician because the patient's unconscious or the two, it still has to be recertified every 180 days in Virginia. And when it is recertified, it only takes one doctor to put them back in their own shoes, because Virginia, the Commonwealth of Virginia, wanted to make it hard to take the decision-making away, but easy to give it back to a patient. Now, once a determination has been made that a patient lacks capacity, the patient has to be notified of this. Of course, in many instances, they may not understand that. They may or they may not, but Virginia said you just have to tell them, hey, we've assessed you and we believe that you don't have capacity to make these decisions. If there is an agent, somebody who can make decisions for this patient, then that person also at that moment, or in a short time frame, needs to be notified of the same thing. So let's switch gears a little bit and talk briefly about behavioral health. So, and by that I mean a patient getting inpatient behavioral health treatment against his or her will. For the longest time, Virginia said, no family member, nobody else can make that decision for a patient, that you would have to go through the ECO, the TDO, the commitment process. And golly, over a decade ago now, it was determined that many individuals who suffered from a long-term psychiatric or behavioral health illness might want to give their family that ability. And so they changed the law and said, okay, in the advanced directive form, there is a section, a very specific section. And the only way a family member can consent to their family member being in an inpatient psych unit is if that patient had filled that out when they had capacity in advance and said, yes, I give my authorized representative the ability to admit me to a psychiatric facility against my will for up to 10 days. And it needs to be on file. I have to tell you, almost never do I feel like we get that advanced directive with that form filled out, but maybe once in a while. I think it's just important to know that that is such a carve out, as are psychiatric medications over the patient's objection. So these are the individuals, it's a little bit longer, who may exercise authority, and those are the individuals that would need to be reviewing it and to help assess the situation. Okay, so judicial authorization of treatment. I'm going to go through this pretty quickly too, but it is a different way to get care for individuals. So I mentioned to you that the family members can't consent to the patient going to a psych facility absent that provision in the advanced directive. They also can't consent to psychotropic medications or psychiatric medications over that patient's objection. Again, unless it's in the advanced directive. So if you have an inpatient and you need those psychiatric medications over their objection, the way to do that is through a judicial authorization of treatment. And it's a specific request of the court. You can do it with the special justices, the same ones that come to do ECOs or commitment hearings, and that would have been part of the TDO process. So just to carve that out as an exception as well. All right, so switching gears a little bit, this is what I've always called the ladder. It is the list of alternative decision makers, and we start at the top and we go down. And we only use this provision of the Virginia law if there's not already an advance directive for that patient. Again, going back to the General Assembly, they said, we want to give patients the ability to decide who they want to make their own decisions. Hopefully they've created an advance directive, maybe a living will, maybe some other guidance documents that could come into play in your situation. But if they didn't do any advance planning, this is the list we'll go by. We'll start at the top and we'll go down until we find the first available rung that is available, that has somebody there. So if we have a patient who lacks capacity, it's been documented by two providers, or a provider who is a treater and a provider who is not a treater, then we go to this and we say, all right, does the patient have a guardian? At some point, did a court appoint a guardian for that patient? That trumps everything else, goes to the top of the list. If not, is the patient married? Because the spouse is always next, unless there's a divorce action pending. Not separation. Sometimes I get that question. If they're separated, that doesn't trigger it. But if they are either divorced or have filed a divorce action, then that takes them out of that spot. We don't always know that, but asking the questions to see. And then from there, we go to adult child. A parent of the patient is after that, adult brother or sister, and then any other relative in descending order of blood relationship. So sometimes that we are out there looking for a cousin or an aunt or a distant relative and have had success in finding them, if there's nobody above that individual. The other thing I'll say is sometimes folks have family and they're estranged from them for one reason or another, and we can bypass them if they say, hey, I don't want to have any part of this. Then we note that and go to the next rung and the next rung until we find somebody who is both the first available on the list and willing. Now, the last bullet point there says friend, with exceptions. When I started practicing law, we did not have this in Virginia. And so individuals who didn't have family, we didn't have any options. And we saw so many situations where there might be an elderly person, for example, with a neighbor who brought them groceries, or maybe they were really active in their place of worship. or religious institution, and there might be folks there who cared about them. And so we worked really hard to get this provision passed that allows a friend, and we need to make sure that they are in fact a friend, and I'll talk about that, to make decisions excluding end-of-life treatment. And Virginia said, taking them off life support or deciding an end-of-life decision seems perhaps too much to give to that friend, but certainly they can step in and help with other consent. So consent to surgeries, help with discharge planning, consent to admission to a long-term care facility, what have you. And that's been quite helpful. The last thing I'll note with this slide is that majority rules if conflict within the same class. So I always use the example of children. So you have an elderly patient, and let's say they have 3 children, and there's nothing guiding us elsewhere. So we need to try to contact all 3 children, everybody in that class. And let's say we reach all 3 children and there's division, and each adult child has their own thoughts on what mom or dad should receive as far as healthcare. The majority rules there. So if we can have 2 children on one side and 1 on the other, we would go the route of what the 2 children want. Certainly it's better if they all 3 agree, but the law just requires us to have a majority. So now we'll use the situation of a patient who has filled out an advance directive in advance of being ill when they had capacity, and we have a copy of it. When does it become effective? This is one that I think folks sometimes get confused. They think, oh, the patient has an advance directive, we should be including the daughter or the son. That advance directive sits on a bookshelf and catches dust. That's it. It's not even effective in Virginia until the patient lacks capacity, and that's been documented. So certainly the patient could say when they have capacity, hey, I want my son or my daughter involved in this conversation. That's fine, they can say that. But we, as the hospital and as the care team, should not be unilaterally involving that agent that's in the advance directive until the document comes alive. And that is when the patient actually lacks capacity and can't make his or her own decisions. And again, I put what that is. They can't understand the nature or consequence. They're unable to make a rational evaluation and communicate it. And at that point, we would kick that document into action. So what do we do if there's nobody to make decisions? We have no family, we have no next friend, there's no advance directive. I imagine many of you have already been in that situation, probably maybe many times, and it's the guardianship process. So I just kind of put from beginning to end, like with the other situations, we're going to note that the patient lacks capacity. We are going to ensure there's no family. And by that, we just have to make good faith efforts. It doesn't mean we have to go to some great length and turn over every stone for their family history, but we do have to do our best to ensure that there are no records of that there's nothing that we could, through case management or otherwise, locate as far as family. That there's no one to consent, no next friend, then we may need this guardianship. And so I always caution folks to kind of hit the pause button there and get your legal team involved for that, because there is a pretty specific legal process for a guardianship petition in Virginia, and certain documents that have to be filed in a certain order. And I imagine that any of you that have been through this have felt like it was an incredibly slow process, and it is. It's something that many of us in the healthcare space in Virginia for a long time have hoped we could find a better solution to and have some better laws for. But the reality is the guardianship process has not changed. And I don't think anybody has kind of the magic bullet for it. So it is a slow process. The petition is filed. The court appoints a guardian ad litem. And sometimes people get guardian and guardian ad litem confused. The guardian ad litem wears a neutral hat. They're not on anybody's team. Their only goal is to visit with that patient, look at what those of us on the hospital side have put forward, look at if there's anybody else disputing it, what they've put forward, and then say to the judge, hey, judge, I have no argument in this. This is what I think is in the best interest of the patient. And that takes some time for that guardian ad litem to be appointed and to meet with the patient. And then the last step is the hearing where the full guardian is appointed. And then we have a decision maker that can step into the shoes of that patient and help us with consent. If ever there's an urgent situation, I encourage folks to get a judicial authorization or to call the court immediately. So it's not getting a guardian. It's basically saying, hey, judge, we need you to make this decision. We need you to authorize a blood transfusion or something imminent. Unless even doing that would cause the patient to possibly die or have permanent injury. And then we can operate under the emergency care doctrine, which is only in common law in Virginia. There's always some risk to that, but I've always said we would certainly rather keep the patient alive than have the opposite outcome. So if we have to move forward without any consent, it really always needs to be documented as emergency, kind of life or limb. Otherwise, we do have to hit the pause button and find somebody who is authorized to make that consent decision for us. So what if the patient is protesting and saying, I don't want to do this. I don't want this treatment. I don't want whatever it may be. Then we need to stop and say, do we have an advance directive? Did they address it in that advance directive before they were ill? Does it not involve life-prolonging treatment? Because Virginia has said if they do not truly want to keep fighting or they do have a thought on end of life, then we would take that out of this rubric. And is it medically appropriate and been documented as such? So that is if the patient addressed it in their advance directive in advance. This next slide is if it's not addressed. So a situation comes up and the patient has never addressed it. And those are the bullet points to go through for that. I won't read them all to you, but again, you will have this if you run into that situation. Key parts being for both slides, is it medically appropriate and has it been affirmed and documented as ethically appropriate by the hospital's patient care consulting committee, or if your hospital does not have a patient care consulting committee, 2 physicians who have not been involved in this patient's care. So you bring in 2 independent physicians, and these have to be physicians who did not evaluate the patient for capacity and were not involved in the care in any way. And for that, really what the Commonwealth of Virginia is trying to say is that if the patient's fighting the care, we want to be really sure that someone hits pause and decides that it truly is in the patient's best interest, it's ethically appropriate, and we're not putting it just on that physician who is trying to provide it on his or her own shoulders. So we're kind of giving that physician some protection to have somebody else look at it and say, check.
I sure didn't.
The patient care consulting committee has a very specific list of individuals that have to be on it. In Virginia, we're kind of divided. I don't know that it's exactly half, but a number of hospitals do have patient care consulting committees now. Many don't. So if you don't, again, finding those physicians or the ethics committee can help you with this too. If you have a patient care consulting committee, these are the individuals that would need to be on it. And they have really 2 roles. I talked about care over the objection of the patient. So the patient saying, I don't want this care. That's one place that could go to the patient care consulting committee. The other is this special friend or the next friend that I referenced. So the next door neighbor, somebody in their church or synagogue, what have you, somebody who has known this patient. And the worry here was, what if somebody comes out of the woodwork and they really don't have the background with this patient? So again, we're putting in a backstop for that physician and that care team to say, let's let the patient care consulting committee take a look at this and decide, do we have some credible evidence? We don't have to be super sleuths, but how do we know that this is an individual that has some history? And again, I won't read you all those bullet points, but you'll have this if you want it, and there's 6 of them for that special friend analysis. And again, if we don't have that, it's the physicians who are not involved. And then the last slide on that is the healthcare decisions over the patient's protest. Again, you will have these for that one. Likewise, it's 2 physicians not currently involved in the care if we don't have that committee available to us. All right. I will take a pause here because I'm about to jump into some scenarios where there's somewhat real life that I've dealt with, but I've changed them to make them generic. If you all have any questions, or within your facility, if you have dealt with really tough, either consent, capacity, kind of questions or difficult discharges where families would not cooperate with your discharge plan or what you were recommending, please feel free to put the questions in the chat. I'd love to make sure that I have time to address anything that might be real life and specific for you all. In the interim, I'm going to jump into these scenarios. Again, they've all obviously been changed, but are loosely based and some more tightly based on real life situations. So here we have Bob Ferguson, a diabetic inpatient who is refusing his blood sugar testing, making it impossible for his care team to monitor Bob's glucose levels effectively, let alone to administer medications to manage his blood sugar. However, he is not stable for discharge and is willing to stay in the hospital and receive most of the other recommended care. So here, Bob has capacity. We see that from the left. Scenario 1 is an adult with capacity. And going back to the beginning of my presentation, as I noted, we don't get to, even if it seems crazy, even if he wants to leave AMA or continue to stay on with the other care till that part's done and continue to refuse the blood sugar testing. There's really nothing in this situation that we can do. He has the full ability to refuse that, and we document that, of course, and move forward. The next scenario is an adult who does not have capacity, and this one's a medical situation rather than psychiatric. So this is 62-year-old Maria Rivera, who was in a terrible car accident about a week ago and is unconscious but stable. She's expected to live, but she's going to require multiple surgeries and intensive care. Her local son, Louis, comes to visit his mom and speaks to the staff, but he often feels overwhelmed by the situation and refuses to make medical decisions, preventing the staff from providing the recommended care to his mom. Maria's other family, she has a mother, a daughter, a son-in-law, a grandson, they're all out of state. So in the interest of time, I'll kind of move along with these, but the reality is he doesn't have to make a decision if it's overwhelming for him. And because it's a son, we need to look at all of the members of that class. So we see at the end of this that she also has a daughter and he has a sister. So we would need to contact the daughter and either see if the daughter and the son could be on the same page, or the son, Louis, could say, I don't want to be involved. It's too overwhelming. The son-in-law has no standing because he's not a blood relative here. And the mother is going to come after Maria's adult children. The other thing I'll note is it doesn't matter where the folks live. It doesn't matter if they're out of state, out of the country. As long as they're reachable, then we can and should take their consent. If after due diligence we can't find them, we are permitted to pass that and go to the next category. Scenario 3 is an adult without capacity. This is both medical and mental. So 98-year-old Matilda Smith is found in the cold of winter on her bedroom floor, naked, in hallucinations, and suffering from a fractured hip. Her next-door neighbor routinely brought her groceries once a week and had noticed that the groceries she left at the door the day before had not moved. She found an accessible entrance to the home and discovered Matilda on the floor. She called 911, followed the ambulance, and told the care team that there was no family and no advance directive or other documents. We believe she's the closest friend. So there we are going to have the treating physician and somebody else. If they're still in the ER, we're going to have them evaluate quickly and note in the record that the patient lacks capacity. And then we're going to escalate it to either the patient care consulting committee or 2 other doctors to look at it and say, do we think that Matilda's next door neighbor is truly the next friend? And if so,
Molly,
she can, yeah,
I just want to interject really quickly. We have a
Yeah.
question.
sure.
Where do stepchildren fall in the class of relatives?
It's a great question. So technically they do not unless adopted. Now, let me pause there and say, if there is nobody else, they technically can come in as a next friend in that last category. But up until you get to the next friend, everybody is blood relatives. And if you're not a blood relative, then like the stepchild again would need to be adopted. And then that kind of changes that analysis. Thank you for sharing that. Are there any other questions, Carla, at present? Or Mary?
That was it for now.
No
Okay,
questions
thank
in
you.
the chat. That was the only one.
Okay, thank you. We didn't talk much about minors, but so I'm only going to briefly touch on that. But minors are in a different category because certainly parents can make decisions for their child unless it is viewed as not being in the child's best interest. So here we have a 30-year-old mom in labor experiencing complications. The OB believes that they both need blood transfusions. Mom doesn't want the blood transfusion. She says she and her unborn baby would be devout Jehovah's Witnesses. And so the reality here is it's fine for her, just like with scenario number one, as an adult with capacity to make her own decisions, not to have blood transfusions. But she doesn't get to make that same decision if it could cause death or permanent disability to her child. And if you enter into that situation, I strongly encourage just getting legal involved pretty quickly. They can guide you on your kind of immediate options on that. Okay, we're down to our last couple of scenarios. 80-year-old Bob Smith has been very ill following an infection and a stroke. He also has advanced dementia. He's unable to make his own decisions, and his medical record properly evidences his lack of capacity. He's been in the hospital a long time. 3 children. Initially, they were cooperative, but now they don't want to make decisions and have essentially housed their father in your hospital. Really tricky there. And in the interest of time, I'll just say you immediately look to see, are they just on that ladder or were they appointed by an advance directive? We often send a number of letters to those family members, and then we escalate it to a judge to remove them as the decision makers, because ultimately they can't just leave a loved one in your hospital. But that's one to get your legal department involved in if you have as well. I'm looking at the time and I'm wondering if I should, if either Mary or Dr. Moore, if you want me just to skip these last few, I'm happy to do that.
Why don't we go ahead and just open it up to questions right now, and then
Sure.
You and Dr. Lewis, you can go ahead and start bringing up your slides while we finish up these questions. There's nothing in the chat right now.
Okay.
Are there any questions?
Okay.
All right.
you.
Well, Ms. Huffman, I greatly appreciate you coming and educating on us when and how to determine mental capacity in healthcare decisions. I will go ahead and introduce Dr. Brittany Lewis. Dr. Brittany Lewis completed her undergrad education at Liberty University. She went on to obtain her doctoral degree from the University of Medicine and Health Science in New York and St. Kitts. She is currently a resident in the Family Medicine Residency Program at Sovah Danville. She is on 2 hospital committees, diversity, equity, inclusion, and belonging. She is the co-chair. She is also a committee member of the Continuing Medical Education. She is a member of 2 professional memberships, American Academy for Pediatrics and American Academy for Family Practice. She also has her work experience includes Yale Medical School. She's was a laboratory research associate in the Department of Pediatric Hematology and Oncology, as well as Yale Medical School in the Department of Ophthalmology and Visual Science as a lab research associate. So I do want to turn this over to Dr. Lewis. Dr. Lewis is no stranger to us. We do see her in the hallways at Sovah Danville. We also see her at the Family Medical Residency Clinic. So, Dr. Lewis, I'm turning it over to you.
Can you hear me?
We
Can hear you now.
And your slides look
Okay,
good.
good. Thank you. Thank you. Thank you so much, Carla, for that kind introduction. I just want to start this evening by saying that this PowerPoint, this research was a culmination, honestly, of my 3 years here so far. And it is still a body of work that can grow. And so my hope is that what I have here can grow in the next resident's hands as we move forward and we learn more about Danville and more about what we can offer our patients. So just starting out, I just want to set up what we're going to talk about this evening. My goals tonight will be to discuss the reason we want to connect patients to services in the first place. And then I hope to explore the available resources, and that falls into two categories. We have individual resources, and then we have the ability to care navigate to those resources, which more so involves placing a accumulation of resources together and packaging for that for patients. Areas where we can grow, and hopefully some introductions to community organizations, as well as time for questions. So to get started, why, right? Why is this important work? Why do we need to connect our patients to resources? There are 5 kind of wheelhouses that connecting our patients typically falls into and helps align them to be better served by. The first one being racial disparities in healthcare, and the second one being poverty as the root cause of disparities. The housing quality, the available costs of that housing, transportation access, and insurance and healthcare system navigation. So if you have worked in healthcare for any amount of days, I am sure that one of these issues has complicated what could have maybe been a simple medical issue, right? Something that as doctors, as nurses, we learned in a textbook, and it maybe had a very simple solution, a very simple medication that could be prescribed to best help that. But because of one of these barriers to healthcare, the patient was unable to kind of get there. There have been 6 areas, particularly in Danville, where we have identified that we can improve our healthcare systems to better help patients. One of them being universal coverage for our patients. That looks like different things for different patients. Funding for additional specialists in the region, better transportation for our patients, clinics that maybe reach our patients where they are, addressing food systems and housing insecurities, and encouraging more civic connection and communication, along with community resilience. If these talking points seem familiar, that is because they all are directly from the 2021 community assessment of need. And so for some of our newer residents, shout out to you guys. If you are unfamiliar with what an assessment of need is, it involves the community coming together. And on this slide, you can see the steering committee. So these are different stakeholders in the community who came together to discuss what would best serve Danville. And there's also one for Martinsville and Caswell County as well. These stakeholders from different walks of life, from different organizations, along with the hospital and backing of UNC, so we'll move on to the next slide, looked at the way that we could all better serve Danville or the community in general. So this shows us the identified gaps, the places that were pointed out where if resources could be made available, patients and the community overall would do better. So let's start with a scenario. We have a 46-year-old African-American female. She comes into clinic for a follow-up to her chronic comorbidities. Those include non-insulin dependent type 2 diabetes, obesity, and essential hypertension. Since you last saw her, she's lost 20 pounds. She remarks when you congratulate her on her weight loss that after losing her job, it's going to be very likely that she loses much more weight. You become concerned after speaking with her and understanding that being able to feed herself, being able to feed her family is going to become an issue. And although obesity is one of her chronic comorbidities, you want her to lose weight in a safe manner that does not include starving herself. And so you begin to look for available resources. And you don't have a real idea of where to turn to first. You don't have something on the top of your mind based on where she lives. So you start by typing in 211 into your computer. And when you do that, it will take you to this website that you see right on top. Get help with 211 Virginia. When you navigate there, you click on that link. It will then take you to a page that looks like this. You have a search tab that would come above this, but you also can click any of these tabs to help you navigate to your patient's needs. You click food and meals because that's what your patient has told you they need, and what they're looking for. And you choose the meal sites as a way that she can begin to get a prepared meal tonight, because it's becoming an immediate issue. And although you would like to set her up with food pantry resources, she needs a meal for tonight. And so you click that. The blue icons identify the places within Danville where she can be served a warm meal this evening. And if you did the same thing with a zip code anywhere else in Virginia, for the most part, it will identify that for you. And then you pass this on to the patient. The reason that we have an updated 211 website is because the lovely folks at the United Way initially made a book, which we refer to by a color, because that color denotes the year that it was published. So the current edition that we have is the yellow book. And there are lots of available copies either at the United Way, and they hand them out to clinics as well, that have a registry of resources. 211 is the more up-to-date version of that yellow book. If you are familiar with interacting with that community resource book in the past, they, going forward, are planning on only updating the website so that that information can be updated multiple times throughout the year instead of just that one book publishing yearly. So that comes to us from the United Way, and that's a good portion of their work. There's also several other programs that are run exclusively by the United Way in Danville. Two of them that might be of interest to you have to deal with a good bit of our population. One is Aging in Place. This is a program that looks at patients who are at the point in their life where moving into a nursing home or a skilled care facility may be an appropriate choice for them, but they are unwilling. And I'm sure most of us have met someone who is, rightfully so, interested in staying in their home to complete their life cycle. This program assesses their needs and fits them with things, if possible, for them to stay there, and helps arrange care from that perspective. The United Way runs this program. Another program that the United Way sponsors is, they are our local branch of the Dolly Parton Imagination Library, which is the largest library in the United States that provides books to children up to 5 years old. And so if you see pediatric patients, once they are born, they can be signed up for this program, and they can get a book a month until they turn 5. This increases early reading, early school performance. So many metrics are improved with early reading. Our next scenario. As we do very often in the summer, as part of the residency clinic, you can find us out at numerous community events where we will set up tables. And so this is not an uncommon scenario where our office would set up a table at a local event in the community, advertising the clinic, meeting the community, getting a better sense of Danville. During one of those events, a young man walks over the table and he shows you his hands. And when he shows you his hands, he says this has been bothering him for some time and he wants to know if he can come into clinic to be seen. He lets you know that he's uninsured, and you tell him that your clinic has whichever form of payment option. But he tells you at that particular time that is not something that can work for him. He doesn't have the means to pay that money. After looking at his hands, though, you are immediately concerned that he may need more urgent care. And regardless of whether he could pay or not right now, he needs to be seen. Does anybody from the audience want to take a stab at this hand finding? It's okay if you don't, but I thought it'd be a fun guessing game. Anyone? Anyone? I'll help you.
Nothing in the chat, Dr. Lewis.
It's okay. The Palmer findings are conclusive for secondary syphilis. And up until very recently, this, well, I shouldn't say very recently, but this is still an ongoing issue, keeping our communicable disease rates down. And one way that we are able to keep our communicable disease rates down is by referring patients, regardless of their means, for quick access to treatment. And so to that end, the health department does testing for symptomatic patients. So symptomatic would, in this case, be this patient's hands, right? He's got a clear finding, and the health department would go from there to test him and can also provide treatment. The health department is also capable for the patients who need that help. If they've been tested but are unable to pay for their medication, if the health department is provided with that testing documentation, so you've done a one swab in clinic, you've identified a patient as having a communicable disease from that, then you can give that information to the health department and they are able to treat the patient with that documentation, even though they cannot afford to pay for over-the-counter pharmacy treatment. Other programs that the local health departments run are a car seat and a pack and play program. What's interesting about both of these programs is that there is parental education that comes with them. So both of these have a class that the parents go to talk about how to safely put the patient in the car seat, how to do safe sleep before giving them the car seat or the pack and play. So if you're on OB and you have a patient who can't leave because they don't have a car seat yet, this is an option. But the family member would, who's picking it up, need to go to that 1 hour class. Other exciting news at the health department, they've hired a maternal community health worker. So her goal will be to increase overall maternity outcomes, including postpartum care, continuing care through pregnancies. And so she will be empowered to work in the whole community. And so if your office or you have patients that are pregnant, I encourage you to reach out to this program to help support your patients. The health department also empowers our free mammogram program. So the funding comes through them and they disperse it to the imaging centers in town. There are a couple kinks on the road here with getting mammograms at every center in town. However, this is the most expedited route if you have a patient who is unable to pay for a mammogram and is over the age where they need a screening mammogram. So this is a great option for that. Another scenario. So this one is a little more hospital based. We have a 67-year-old patient, Caucasian male. He's got a history of alcohol dependence and essential hypertension, peripheral arterial disease. During this admission, he was newly diagnosed as type 2 diabetic and quickly required insulin. He's been in the hospital for 12 days due to initially delirium tremens that required intubation. He's now made his way onto the floors where he's working with physical therapy. And after their assessment, they feel like he could really benefit from some skilled rehab. However, given the patient's insurance, they are not going to cover the full extent of what rehab would be for this patient, and whether he's used up his skillable days in the past, which Ms. Carla can tell you all about her pain and suffering in that avenue, or he just doesn't have them to begin with based on the insurance or being out of state. He is simply not a candidate to go to a skilled facility right now. But it is time for him to be discharged because from your perspective as his doctor, he is medically ready. You have done all the good that you can do for him in the hospital. So what do we do now? Right? This patient has to go home, but he does not seem to be ready for home. So we have a couple organizations in town that organize what's called community health workers. This slide is entitled REACH because they are the organization that in a lot of ways oversees all of the community health workers to some extent. The initial grant is through them. And so for the most part, most of the community health workers have some association, either financial or employment wise through REACH. But what is a community health worker? If you've never worked with one, it might just seem like a very loose, arbitrary term, right? Community health worker serves to navigate a patient's needs by connecting them to available resources. And that looks like a very broad definition because it's supposed to be, right? This is someone who meets a patient where they're at and helps navigate them based on the goals that you have set, particularly if you are an involved physician, the goals that are set moving forward. And one of the first steps in community health work is to connect them to a primary care doctor if they don't already have one. And so that navigator ideally is working with that physician and discussing those outcomes so that the patient is moving closer to those goals. And so in the case of our patient before, who likely needs an endocrinology follow-up, who may or may not need a neurology follow-up, who is absolutely going to need close hospital follow-up at a clinic with a primary care doctor. When they leave the hospital, particularly for a patient who is unfamiliar with the healthcare system or who has low literacy in general, whether that be healthcare literacy or overall literacy, giving them a community health worker upon discharge allows them to have an advocate as they are going through this process that will better understand the system that they are now new to. REACH, along with operating community health workers and having that program, they also, I wanted to make note, have a community health program where they go out into the community and discuss different topics. So it won't be unusual to find them at Cardinal, per se, or any other of our nursing facilities around town, Stratford, where, or the libraries or the community centers, where they would then give a program where they discuss different health concerns. So I've been to one at the community center where they taught Tai Chi for arthritis. So that's another offering that Reach backs. PATHS also has community health workers. So if you are discharging patients and you look at their needs and you see that a community health worker and maybe some of the other offerings that PATHS have would work well for your patient, you know, if you're discharging them with a dental abscess and they don't have insurance, PATHS is a great option, right? Because they are a nonprofit that offers dental care, that has community health workers, and has dental care.
Dr.
And
Lewis,
so, yes,
quick question that's in the chat.
of course.
I'd like to know if all the resources on these slides are on the 211 website.
To some extent, yes, but the community health workers and what they offer is not. So the individual breakdown of what each community health worker office gives is not on there. Not to this extent, no.
Thank you.
But please, you're welcome to these slides. Do with them what you will and ask as many questions as you need. I will offer you anything I've learned. Gateway is another organization that works very closely with our hospital. They have community health workers. They also have a program called chronic care management. This is an offering for patients with particular insurance, usually Medicare and then Medicare adjuncts, where they help with the navigation of their care specifically. So they are looking at outcomes for anybody with 2 or more chronic comorbidities. So the community health worker program, it's kind of general, right? That's someone you think that needs more help navigating through the healthcare system and having clear outcomes for whatever their particular situation is. The chronic care management is looking at those particular comorbidities that you've identified. So in our community, it's not an unusual pairing to have insulin dependent type 2 diabetes and raging uncontrolled hypertension. It's a pretty normal combination. And so chronic care management would work with your patient on if they're taking their medication daily, if they're seeing their specialist, do they understand how to check their blood sugar? This program is designed for those chronic condition management. And the difference between this and the community health worker is just that particular need in the chronic care management for the patient to be a Medicare patient and to have those chronic comorbidities. This is a really interesting offering that I think is very unique to Danville. The Life Saving Crew, which most of us know as local EMS, they have a program where they have paired community health work with paramedics, which I think is such a beautiful offering. I think I can, give a short testimonial about a patient that I have and how this work has been particularly helpful to me as a family physician. I have a patient who was discharged from the hospital in early June. Her hospitalist sent me a message letting me know the circumstances from which she was discharged, that she would have likely been better placed at a skilled facility, but due to a number of circumstances, she would not be going to one, and that this patient would need very close follow-up. I then see the patient and I find out that although they are supposed to be on at least 4 doses of insulin in the day, they are only getting 2 at best of those doses. We check sugars, we recheck all the labs, and everything looks essentially as abysmal, if not worse, because we're not getting the right medicine. Why aren't we getting the right medicine? Well, the patient doesn't have appropriate dexterity in their hand to give themselves insulin. They can't turn an insulin pen, nor can they inject if I was just to give them an old school vial. And so they had been given aids, but not all aids have the certification to give medicine. And so their nighttime aid could not give them their Landis. So this particular patient has been followed by the life-saving crew for some time, and they are well cared for by them. They are checked into by them, and I was immediately able to not only reach out to the aid organization and discuss changing around the schedule for which aid was to see this patient so they could get appropriate medication. I could reach out to her community health worker and talk about her discharge and talk about what we needed to do to keep this patient safe and to keep the doorway of conversation about moving towards skilled placement open. And they have been a great help in that conversation. I would be remiss if I didn't talk about my own clinic and the offerings that we have for patients in need. We offer sliding scale, which is essentially you bring in proof of your income, and if you make below the poverty margin, you 250%, which is what's considered the poverty margin, you qualify for a much reduced price. And in that same wheelhouse, because we can do that, we can offer these other services such as pediatric coverage for vaccines and OB care and routine gyne care as part of that. Other issues that come up very often in Danville are transportation. And so this is a map of the Martinsville transport system and the bus system. This is a map of the Danville, transport system. If you look at where I've circled on the bottom right, you can see where it says reserve a ride. So things being what they are, this is a option, right? Sometimes they come, sometimes they don't. But it is a option that we can navigate our patients to when we are discussing obtaining a ride, whether it's to come to clinic or go to their specialist office. There are also the options that are through their insurance plans if they do have them in terms of Medicare rides. But this is an option if that isn't available to your patients. Where can we grow, right? What are the things that I didn't identify in here because we still need more of? Transportation, right? So there have been many patients that we have gotten appointments at UVA or Carilion or for specialty care in particular, but we don't have appropriate transportation or timely transportation to get them there, depending on their insurance. And that has been a barrier to care for us. There's also specialty care, right? So the ability for patients to see a specialist in our own community, a place where that has maybe been noticeable in my career has been in the behavioral health arena. Particularly for pediatric behavioral health, when you're looking towards the continual treatment of autism. We have great centers close by in UVA, in Lynchburg, in Roanoke. But if you have managed a patient with the giftings of autism and all that is special with them, for them to grow and to flourish, they need pretty regular therapy sessions, right? Sometimes multiple in a week, whether it be speech or occupational therapy or psych management. And so for a family to take on the burden of doing a trip to Roanoke or doing a trip to Charlottesville multiple times in a week does not usually last, does not build itself towards sustainability. And so having more resources in town would always go further for our patients. And then, of course, partnerships between the community and medical providers. Where can we grow? What can we learn from each other? This presentation is entirely based on things that Danville has taught me, right? I knew nothing of this before I arrived in Danville, and now I know. Now I know these things, and they are skills that I hope we can all take forward with us. This, again, it's the areas of improvement that were pointed out by the 2021 community needs assessment. And, we can see the places that since 2021 we have grown and we have made leaps in, particularly in that civic caring, the community resilience areas. But we also have lots of room for improvement and places where we can all join in and help grow. I wanted to make some introductions, whether they're on the call or not, and to thank these folks for meeting with me and explaining the way that their organization worked and explaining the offerings that they had. And everyone on this slide made it clear that this was not just for me, but they were more than happy to speak with any provider that had an increased desire to speak with them and to go forward in that program. So Ms. Kathy Waller at the health department, she's the senior nurse. Mr. Keith Carroll, he is not only in charge of the community paramedic, community health workers, but he is a member of the life-saving crew and has been for some time now. Brandon Dudley of the REACH initiative. Ms. Carol Gore at the United Way, and Monica Crew of Gateway. And this by no means is a full list of all that Danville has to offer, but these were some of the folks that I spoke with. I want to point out the 2021 community needs assessment for both Danville and Henry County that I use. And then I wanted to say thank you to a couple of people. I know, interestingly enough, the first person that I'm thanking is not someone that's with our organization any longer, but I still very much would like to thank Dr. Roach because she was my first preceptor when I first got to town, and I was bright-eyed and bushy-tailed and had lots of ideas, and I had lots of things that I wanted to start and lots of things I wanted to do. And one of the first things she asked me was, did I know anyone from Danville? Had I met anyone from Danville? And my answer was, yeah, I know our patients, right? I see patients in her clinic every 5 minutes. But that's not what she was asking me. She was asking me if I truly got to know Danville. And I truly understood and had a heart for the people that live here. And once I did that, I think it was much easier for me to work towards navigating their needs and their resource needs. A huge help in that effort were all of the nurses that I've met, whether it's on 4, 5, or 6A, or my OB nurses, or probably near and dear to all of the residents' hearts, our residency clinic nurses, who deal with our constant barrage of patients don't have X, but I need them to have it. And were the first patient navigators that I met because they were very used to connecting patients to what they needed. And then again, I want to thank Dr. Moore and Ms. Kent for giving me this opportunity to share this presentation and to have this time with all of you.
So,
I'm open to
Dr.
any
Lewis,
questions.
We do have some questions in the chat. I don't know if you want to maybe bring your slides down and that way you'll be able to see the chat more easily. And
I can do it as soon as I figure out how. Okay.
Kay, did you want to read your question? Or just want Dr. Lewis to read over it? She has that first question or comment in the chat. She works with the health department.
Ah.
Do you see that? And
Yes, I'm reading it. Okay. So yes, this is very helpful. Yeah, the example, I chose syphilis intentionally. As a resident, it was one of the things that I think we needed to be more comfortable with. And for us to be able to spot all of the stages. One thing, and I'm looking at it. I want to make sure that I'm answering your question, Ms. Shelton, and if I'm missing it, please tell me.
Her mic isn't working, so
Okay.
she will type something in if she needs
No,
to.
perfect. So I'm reading it, and I agree that the understanding of syphilis right now is very timely. And I know that as residents, we are constantly refreshing ourselves with questions so that we can recognize it and early treat it. I think another thing that has been really helpful to us is lowering bias and lowering stereotypes about who and when syphilis should happen. And I think by doing that, we end up missing less folks and making sure more people get the help that they need. In terms of the dental resources, I know that PATS has had historically a very long waiting list. What we've had to do in our clinic is maybe refer a little bit further out or wait for days that the bus is moving. And then when the bus is working, they will do some amount of dental care on that bus, like in that moment type. So finding out the next offerings for the bus are particularly helpful. And then if your patients are willing to go between not just Danville, but Chatham and South Boston, like the other offices, then you usually will have a better chance. That's what
Dr. Lewis, excuse me, it's Dr. Moore. Please read the question you're being asked so everyone knows what
I'm
you're
sorry.
responding
Okay.
to.
So this last question, I was talking about the difficulties in getting dental care, and with us only having limited providers in the region, how challenging that can be. And so some of the ways that we've navigated that have been to use more than just the local clinic to call around. And then it's not terribly unusual for us to, I have given my patients their clinic note from that day, when they've come in for a dental abscess, when they've come in for that toothache. And sometimes that has helped to expedite the visit. And then Ms. Compton asked if we need a business agreement. So for any of these navigator options, no, because for all of these available options right now, as far as I understand, and Ms. Carla, you can please correct me if I'm wrong, we have an established relationship where if a provider is discharging from the hospital, I can select in a face-to-face that I am referring them to a patient navigator, and then that gets distributed from there. Am I correct?
So with the REACH program, there is a agreement. LifePoint attorneys, prior to me coming on, had reviewed, and there is an agreement with the REACH program. If it's a referral for an external, generally what happens is we talk to the patient, case management will talk to the patient, and case management will give that agency information to the patient. If the patient want us to make contact, then we will get a verbal agreement from the patient to say, but for an example, if it was the God Storehouse for food, then I would tell the patient, God Storehouse, this is where they're located, this is the date and time. So then I'm not giving out their PHI, they're going to that facility or to that agency to get the service that they want.
Yeah,
Yeah.
hey, this is Pam. I was just thinking more on like the Life Saving Crew, the program that they run, which is amazing, by the way. That is something that I think this community could really use, and we could use to help us. So Keith, if you're still on, I think I saw you out there. Thank you. Uh, but but I just want to make sure that we're doing this the right way. So I
Yeah.
don't think we have any type of agreement or anything with them, but I can see where in that case we would be sharing some pretty specific
So,
information. So Molly,
so,
I don't know if you want to weigh in on this, or just so
so
everybody can
Pam,
hear it.
Pam, there is an agreement with the REACH program. Danville Life Saving Crew is a part of that REACH program. So there
Okay.
is an agreement. Now, do I have the agreement in my file? No, I don't, but I do know there was agreement. And then there was the legal team at Life Point who worked on that agreement, or it had to be signed off. So
Okay.
that happened when the REACH program first started with Sovah. Now, with that, the patient has to agree to participate.
Right.
Mhm.
Right.
And one thing I'll add, and this is the reason I tried to make it clear, but I know there's so many different organizations that do similar things. Reach is the funder. And so as the funder, the grant that basically houses all of the community health workers, with the exception of the health department's health worker, that's a separate entity, but all of the other community health workers are under that REACH grant. Which is why it's valuable to us that we have that contract with Reach, because the Life Saving Crew, Gateway, and Paths, all three of those are just essentially under that Reach umbrella.
Okay. That makes me feel much better. Thank you.
Yeah, and in the clinic, it actually works a little bit easier for us to just hand the patient the card. So I give them Keys card, or I give them Pass card, depending on what I'm needing them to do. Just in terms of, there's no formal way in Athena to send information, even if I had the desire to. And it does cut down on sharing PHI. So the goal is to connect the patients, but in the safest way possible.
There
Dr.
was a question
Pradhan,
from Dr.
Doc,
Yeah.
Dr. Pradhan did a comment at the bottom, kind of related to community outreach.
No, there is no, so Dr. Pradhan, there is no cost for the community outreach via the Life Saving Crew. This is, again, funded under that initial REACH grant, and they have 3 qualified health workers. With the last time I checked with Mr. Carroll, they have lots more time on their dance card. So if you have patients that need this service, they would be happy to help you. You can reach out to Keith Carroll at the Life Saving Crew, and there is a process to enroll your patients, where they talk to them and assess their needs, right? Do they need food? Do they need transportation? And how can they best help them navigate that? But it is a completely free program.
Thank you. And Molly, did you see the question that Dr. Adandi put in the chat earlier, like right at the conclusion?
About the baby
pregnant.
being born. Yes. So that slide was intended to say that the mom still had capacity right before she was going into delivery and didn't have anybody with her, like the dad. So you were right, that, but it was intended to be for when the baby was born, not while the baby was still a fetus.
Thank
I
you.
think there was one other question for Dr. Huffman. Ms. Huffman, where do stepchildren fall in the class of relatives?
She answered that. Yeah, she covered
Did she?
that during.
Okay.
Yeah, thank you, Dr. Moore.
Okay. Sorry.
That's all right.
Okay.
Well, Ms. Lipscomb, thank you for moderating the program this evening. Thanks to our speakers. Are there any last minute questions? We're just about at our time limit, and any final questions, concerns, complaints that anyone wants to voice before we bid you adieu? Okay, well, thanks so much to our two speakers and to Ms. Lipscomb for facilitating the evening, Mary Ken and Jennifer Goodman for getting all this organized. I hope we can see you back in about 2 to 3 weeks in August on the 21st, Thursday evening for the esophagus management disorder review. And we otherwise, as I remind the residents when I have the privilege of talking, teaching them, please be careful out there, and we look forward to seeing you back. Have a great evening. Try to stay
Thank you,
cool. Good
everybody.
night. Bye-bye.
Thank you.
Bye.
Bye-bye.